Here I am once again, Mentor Ray, your fact check buddy. Now I'd like to discuss with you the difference between Alzheimer's disease and Pick's disease, which is, okay, a type of frontotemporal dementia. Okay, so from being your mentor, I am now your fact check buddy. And before we get to start our discussion, let me shout out to one of our passers. Congratulations to Maria Lourdes Torres Quijano of the University of Perpetual Health System, okay, who is now a USRN, and she passed the New York Board of Nursing last July 19, 2021. If you want to be like them, our passers, join me in my 45 days Power Pack exclusive NCLEX RN test preparations review class starting September 11, 2021. Okay, so I also would like to ask you to join me in this mission to provide free NCLEX application and review to 100 nurses to help achieve this. Just watch and finish the ads in our videos. Thank you. So let's begin our discussion and differentiation of these two types of dementia. Now, when we say dementia, it's usually progressive and irreversible. So is it something that is expected with aging? No. Cognitive impairments are considered not part of healthy aging. So you're not expected to have Alzheimer's. You are not expected to also develop frontotemporal dementia or Pick's disease. So let me first begin with a functional concept. Unlike Alzheimer's disease, in Pick's disease, symptoms occur earlier. So the onset would usually be between the age of 40 to 50. Then behavioral problems occurs within those time. Then making sense of their words and that of others is difficult. So this is the difference. In Pick's disease, they have difficulty understanding their words and that of others, which may not occur until late in Alzheimer's disease. Now, in Pick's disease, there are no delusions and hallucinations. Unlike in Alzheimer's disease, they have delusions and hallucinations. Memory problems are not that much in Pick's disease. And in fact, their spatial orientation or their ability to recognize their environment is intact in Pick's disease. Unlike in Alzheimer's disease, they usually get lost in familiar places. In Pick's disease, that does not occur. Getting lost in familiar places does not occur in Pick's disease, okay? Now, here are some concepts and functional concepts and questions related to Alzheimer's disease. Okay, now, another thing that we need to be focused on, if you are studying for the NCLEX at this point, would be your Alzheimer's disease, which is a form of dementia. Now, is it enough to just focus on Alzheimer's disease? I would advise you, no. Try to study Alzheimer's and try to study other forms of dementia, like, for example, frontotemporal dementia, like your Pick's disease. Okay, and then try to identify the similarities, the way that we did it for prostatitis and BPH, and the differences. So what is important, therefore, is that you know what Alzheimer's disease is. Okay, so the main problem in Alzheimer's disease would be the development of senile plaques. Okay, that could be associated with the presence of your amyloid. And this leads to the destruction of the neurons that secretes acetylcholine. So once acetylcholine is decreased, learning and memory also decrease. Now take note that your acetylcholine is responsible for preservation of memory. Okay, so let's pay particular attention to these functional concepts. First, a protein called amyloid beta is the hallmark of Alzheimer's disease. Okay, so which means it is the diagnostic marker for Alzheimer's disease. So genetic tests can help diagnose Alzheimer's disease because they have found a potential familial predisposition or genetic predisposition to Alzheimer's disease. Well, it could sometimes be genetic, or sometimes it could be that because the same family members stay in the same environment, then there could be an exposure to substances, like some studies identified aluminum that is accumulated in the brain. And if one family could be diagnosed, all members could be diagnosed with Alzheimer's disease. They could be using the same utensils, they could be staying in the same location where there's a high concentration of aluminum. So it needs more validation to say that it could be associated with environmental factors as well as genetic factors. However, genetic tests can help diagnose Alzheimer's disease. Memory loss is the key symptom of Alzheimer's disease, but this is very difficult to identify because some of us, most of us, would usually associate memory loss with normal aging. We think that this is expected when your patient is growing old. But remember this class, remember this functional concept. Cognitive deficits are not expected as you age. So it simply means you're not expected to forget things when you grow old. Although most of us would say, oh, I forgot my appointment. I'm getting old. That could be our personal belief. But for some, could be beginning signs of Alzheimer's disease. I'm not trying to frighten you, but what I'm trying to say is it is a possibility. Okay? Now, your Alzheimer's disease could begin with mild cognitive impairment. So the initial stage would be your MCI, mild cognitive impairment. And I created a code, also MCI, okay, which stands for memory changes. So frequent forgetfulness, cognitive impairments, okay? So they forget details of the conversation and they would say, you didn't tell me that, even if you told them about it. Impaired ability to recall details of conversation, recent events, or appointments. So loss of memory of recent events, that's your anterograde amnesia, okay? Or this could be inability to learn new things. You just taught them how to do something and then they immediately forget it. So they used to be fast learners and they eventually become slow learners. And sometimes we attribute this to aging. So mild cognitive impairment may not necessarily be noticeable, especially for those who are not trained to identify these kinds of things, okay? They think it's a normal part of aging, but it's not. These are all beginning signs of Alzheimer's disease. Now, mild dementia due to Alzheimer's disease is characterized by, okay, mild dementia. Okay, this is now your mild Alzheimer's disease. So you have the code mild. Memory loss of recent events, okay, or anterograde amnesia, increasing difficulty with problem solving or complex tasks and judgment. A common manifestation of this is that they will have difficulty balancing checkbooks. They are issuing and issuing and issuing checks, even if they no longer have money in the bank, okay? Now, there's also loss of previous functions, or there's reduced motivation, okay? Avolition, that's a medical term, social withdrawal, and aphasia. Aphasia is inability to find the right words to say, okay? That's expressive aphasia. They are unable to find the right words to say, or they have difficulty identifying the words, and sometimes they have difficulty understanding spoken words. So that's receptive aphasia, okay? Now, your aphasia does not just occur in Alzheimer's disease. It also occurs in frontotemporal dementia, okay? Because in frontotemporal dementia, the frontal lobe and, okay, including the Wernicke's area in the temporal area, okay, the Broca's area and the Wernicke's area are affected. And so the patient may also have expressive aphasia or Broca's motor speech aphasia and Wernicke's aphasia due to the affectation or receptive aphasia due to affectation of the Wernicke's language area and the area of comprehension in the temporal lobe of the brain. Now, D, diminished ability to organize or they usually get lost, okay? And then they misplace belongings. Now, the difference of a patient with Alzheimer's disease to that of a patient with frontotemporal dementia or Pick's disease is that for patients with Alzheimer's disease, they get lost even in familiar environments. That's why when they are in the unit, we never ask them to wear shoes because they would think that they are going somewhere, and that increases wandering. So it's very important that when they are in the unit, we allow them to use slippers instead. Okay, for patients with frontotemporal dementia or Pick's disease, okay, their spatial orientation, meaning orientation as to space, orientation as to where they are, is usually intact. So they don't get lost in familiar environments. That's your Pick's disease or frontotemporal dementia. And those who usually get lost in familiar environment are those who are having Alzheimer's disease. So it's very important, since these are cognitive impairments, your priority should be to frequently reorient the patient, okay? And sometimes they have a tendency to misplace their belongings. So you would see the car keys inside the fridge, or you would see their wallet, okay, inside the sink. So this could be common observations for patients with Alzheimer's dementia. Then moderate dementia due to Alzheimer's disease is characterized by moderate, okay? Moderate dementia, moderate, okay? What are these? Memory loss, like confabulation, or they make up stories to fill in memory gaps. So since they have forgotten the details, they create stories to bridge their memory gap. Okay. Now, this is actually to protect their self-esteem. So we allow them to confabulate, allow the patient to do that. Now, they also have inability to recall personal history. They don't know who they are. They don't know where they're from, including their phone number. So it's very difficult, especially for patients with wandering. Now, they could also have outbursts of aggressive physical behavior. So they act out, and this could potentially lead to a violent reaction. So it's very important that we manage this and avoid agitating the patient. Deepening confusion. So they will become disoriented as to time, place, and person. So initially, they don't know what the time is. They don't know where they are. Then eventually, they are unable to recognize the nurse. So you always have to introduce yourself and tell them your role. And then this is the time when wandering occurs. So they walk and walk and walk until they go to and reach a specific place and they don't know where they are. Okay, they would also have exaggerated or unfounded suspicions. They think that a family member is getting money from their bank account. They accuse their husband or wives of having affairs. And sometimes they have a tendency to believe that these are real. So it's very important for the nurse to know that this could be unfounded suspicions. Okay. Patients in the moderate stage of dementia love to repeat their favorite stories. So you would usually hear them talk about these stories over and over and over again every day. So they talk about their dog. They talk about how they used to be admired by a lot of people once again. And sometimes you would note that their stories would have different versions because they are having memory gaps. So they are just trying to confabulate to fill in the memory gaps. And then they would usually have agitation, which means they're having anxiety and restlessness late in the day, especially when the sun sets. So we call this your sundowning syndrome. So confusion that increases as the sun sets is what we call sundowning syndrome. Confusion that occurs as the sun rises in the morning is what we call your sunrise syndrome. So whether you're having sundown or sunrise syndrome, there will be disorientation. So it's very important. Your priority is to orient the patient. And then eventually they will have troubles with activities of daily living. So they will have bowel and bladder incontinence. So you have to assist them with bowel and bladder elimination. And then take note, they will also have difficulty choosing the right clothes for the weather. So sometimes they would wear sleeveless shirts during winter, and during summer, they would wear their leather jacket. So if you see an old patient wearing a leather jacket during summer, suspect Alzheimer's. But if you see a Filipino, not old, but wearing leather jacket during summertime, he's the action star in Philippine movies. Okay, and then they usually would experience visual and auditory hallucination. Now, this is very typical with patients with Alzheimer's disease. Look, they have exaggerated or unfounded suspicions, which could be a false belief. So it's a delusion. And they are also having hallucinations. So sometimes patients with Alzheimer's are given antipsychotics because they are having delusions and hallucinations. Okay. Next, severe dementia due to Alzheimer's disease is characterized by, take note, severe. They speak incoherently, speaks incoherently. So they themselves will not be able to understand what they're saying. Then they have extremely rigid muscles, which could be mistaken as symptoms of Parkinson's disease. The vocal cords get weaker, so their voice could be softer, and then excessive difficulty and loss of ability to swallow. So that makes them at risk for aspiration. And then eventually, in the severe stage, they require total assistance with bowel and bladder elimination and all activities of daily living. And then they experience a decline in physical abilities, like difficulty walking, they're unable to sit. So you will have to assist them regularly. So let's try answering a sample question. Which of the following interventions are appropriate for patients with Alzheimer's disease? Select all that apply, okay? Provide some choices every day, like asking the patient to choose from 2 outfits. Yes, this would enable them to exercise making a decision. Okay. However, you have to limit the choices to two. Do you want the black or the white? Do you want coffee with cream or without the cream? Not too much choice, because too much choice could agitate the patient because they get pressured for making a decision. Use clear one-step communication. Yes. Okay. Limit daytime naps. Yes. Otherwise, the sundown syndrome, that is agitation and confusion that occurs when the sun sets or at nighttime, could be aggravated if you don't limit daytime naps. So yes, we put a check. Turn off the TV at mealtime so they get focused. They don't get overloaded with stimulus. Yes. Consider buying identical outfits if preferred by the patient. Some patients, especially the elderly, would want the same set of shirts, the same set of shoes, the same set of underpants. Then you comply. Okay, because even patients with no Alzheimer's disease do that. I myself do that. I have several pairs of my favorite shirts because I love the fabric, and the same is true with them. Stick to bathing schedule even if it's met with resistance. Now take note of that some of them may forget that they have taken a bath. You would see them naked and they have taken a bath an hour ago. So you always have to assist them and say, if you feel dirty, I will have to assist you in washing yourself, or present reality, tell them that they have taken a bath an hour ago, but if they still feel the need to wash, then they can be assisted. But do not be too rigid with schedules, especially if it is met with resistance. So this is an X. Okay, so what are the drugs for clients with Alzheimer's disease? So you have your cholinesterase inhibitors. This drug prevent the destruction of acetylcholine. So in essence, it helps decrease the signs and symptoms. So you have your donepezil or Aricept, galantamine or Razidine, and rivastigmine or Exelon. You have the code ARE. So it will help improve agitation and depression. So the common side effects would be insomnia, nausea, anorexia, diarrhea, and a potential cardiac arrhythmia. That's why you have to check the heart rate. And then you have your Mementine or Namenda. Okay, what is Mementine? It's an NMDA antagonist, which simply means NMDA is N-methyl D-aspartate receptor antagonist. What does it do? So your Mementine blocks glutamate. Okay, glutamate is found in clients in the seasoning that we do. Remember your MSG, in the Philippines we call it betchin, monosodium glutamate. Okay, your glutamate is a substance that helps facilitate learning and memory. Okay, however, why do we need to block glutamate? Because when there is excess glutamate in the brain, it overexcites the nerve cells in the brain, the neurons. And when the nerve cells are overexcited, it could lead to rapid death. And that accounts for the loss of memory and the inability to learn new things. That's the reason why people were saying MSG, too much use of MSG could lead to Alzheimer's disease. Well, it could be a possibility. Now, remember that your Mementine is not a cure. It is given to slow the progression of symptoms or to treat the confusion. Okay, so the common side effects would be dizziness as well as confusion. Okay, so what is actually funny here is that Mementine is used to slow down the symptoms, including confusion, but a common side effect could also be confusion. But sometimes, okay, the use of the medication outweighs those side effects. Okay, now let's talk about Pick's disease or your frontotemporal dementia. Let's begin with a functional concept. In frontotemporal dementia, the parts of the brain that are responsible for personality, behavior, and language shrink. So the frontal as well as the temporal parts of the brain are to undergo changes like atrophy. So there's shrinking or atrophy of the frontal and the temporal parts of the brain. Okay, so remember, this would actually require us now to recall the lobes of the brain. You have this in your nursing NCLEX 311, page 233, for those of you who have the book. For those of you who don't have the book, if you may want to purchase one, get in touch with us through our email. So the frontal lobe is responsible, here's the frontal lobe, labeled A, is responsible for Broca's motor speech area, and that's going to be the left frontal lobe, okay? The language, okay? So that when the Broca's motor speech area is affected, the patient will have expressive aphasia. They are unable to find the right words to say. So if the frontal lobe is affected, patient will have expressive aphasia. It also is also responsible for motor functions and movements, as well as memory, control of morals, emotions, judgment, personality. So the personality changes results from the affectation of the frontal lobe of the brain, and problem solving, impulse control, reasoning, and planning. So remember the 3 P's of the frontal lobe: personality, problem solving, planning. So the inability of the patient to plan would mean impairment of the frontal lobe. So therefore, if you are to be asked, when the patient experiences aphasia, which part of the brain is affected? You put an X on this part, labeled A. That's your frontal lobe. Next, the parietal lobe, that's labeled B, okay, is responsible for SPO, sensation of touch, temperature, pressure, and taste. And it's also responsible for pain interpretation and orientation. So if the patient becomes disoriented, which part of the brain is affected, put an X here, labeled B, okay? It's also responsible for your reading and arithmetic, okay? Temporal lobe, you have here your Wernicke's language area, the area for comprehension. So you have auditory center or hearing, memory, that's why you would usually say, I can think of it. You're trying here, memory. You don't say, I can think about it, okay? And put on your finger to your occipital lobe. We usually point here, temporal lobe, okay? So memory, perception, and recognition, then Wernicke's language area. And then, so if you'll be asked which part of the brain is responsible for the symptoms of a patient with receptive aphasia, inability to understand spoken words, that's going to be Wernicke's aphasia. So the Wernicke's area, the temporal area here. So if it is expressive aphasia, put an X on this part, labeled A. Receptive aphasia, put an X on this part, labeled C. For occipital lobe, this is for visual processing, okay? So frontotemporal dementia occurs earlier than Alzheimer's disease. The risk for development of frontotemporal dementia increases with family history. In frontotemporal dementia, spatial orientation is intact, which means they are oriented to their surroundings. They do not get lost in familiar environments, okay? Now, what are the manifestations of your frontotemporal dementia? Please do remember this, and please pay particular attention to how I describe this. So there are 3 categories: behavioral, speech and language, and movement disorders. If you will be asked which of these 3 categories would occur first, then we have behavioral. Remember our code: lapse, talk, trump, okay? Okay, you can use this, but please do acknowledge that it came from our system. So lack of inhibition, judgment, and empathy. So these people, when they are angry, they have a tendency not to consider the feelings of other people, okay? Frontotemporal dementia manifestation. They are judgmental, okay? Their judgment is impaired, okay? And sometimes you get to see them like walking naked because of the loss or lack of inhibition. And then apathy, no emotional expression. Then you would notice a decline in personal hygiene, emotional rigidity, that's considered personality changes, and then smacking lips and other compulsive behavior. They would usually also have pica, or they eat inedible objects, or they love to eat excessive sweets. Sometimes they eat even soil, or they eat plastics, okay? And sometimes they stuck on ice chips, that's pretty acceptable, but soil and plastics are not. So you have eating inedible objects as a common characteristic, okay, of patients with frontotemporal dementia or Pick's disease. Speech and language, they will have telegraphic speech, which are usually broken. They are having difficulty finding the right words to say. That's why their speech are broken, okay? It's like telegraphic speech, the speech of a preschooler. They will have aphasia, expressive aphasia due to frontal lobe affectation, because you have the Broca's motor speech area in the left frontal lobe area. Receptive aphasia, inability to understand spoken words, or Wernicke's aphasia. This is due to affectation of the temporal lobe. Loss of ability to know word meanings and knowledge of word meaning is lost. Okay, so they are groping for understanding words because they seem to have forgotten the meanings of words. Okay, for movement disorders, you would notice they have manifestations like patients with Parkinson's disease. So it's like patients with Lewy body disease, right? So they have tremors, rigidity, underactive or difficulty swallowing. That's why they are at risk for aspiration. They also have muscle weakness and mood swings. Sometimes they are irritable. And of course, they have poor coordination. So don't forget, once again, LOPS, talk, trump. Okay? So if they have behavioral, okay, problems, your nursing diagnosis could be impaired social interaction, okay, because of the behavioral problems. Now, for speech and language, okay, again, okay, your patient could have impaired social interaction because of their inability to find the right words to say and to understand spoken words. And then impaired physical mobility or risk for injury related to the movement disorders like incoordination or poor coordination and muscle weakness. Okay. Currently, antidepressants reduce the symptoms of frontotemporal dementia. Now, take note that these patients are given antidepressants, okay, in order to reduce the symptoms, not to manage the depression that comes with the disease. So let's try answering a sample questions. In the treatment of clients with frontotemporal dementia, the administration of antidepressants is made in order to, is it one, treat the accompanying depression? No, that doesn't occur. Reduce the behavioral symptoms? That could be a potentially correct answer. Decrease tremors and rigidity? No, that's not the rationale for the administration of antidepressants. Enhance physical mobility? No. So the best answer would be number 2. Reduce the behavioral symptoms. Okay. Which of the following are behavioral manifestations of frontotemporal brain syndrome or dementia? Okay. Now, when you are being asked behavioral manifestations, okay, so focus on that. Just identify the behavioral manifestations. Apathy, yes. Pica, yeah, eating of non-food substances or inedible substances. Loss of empathy, yes. Muscle weakness, this is a motor behavior. It's not a behavioral problem. Incoordination, once again, this is a motor related symptoms or physical symptom, not related to behavioral symptoms. Okay. Next, in the treatment of clients with frontotemporal dementia, which of the following goals of care would be the highest priority of the nurse? Provide frequent orientation, prevent aspiration, prevent suicide, facilitate mobility. Now take note, in Alzheimer's disease, the priority would always be orientation because they are unable to recognize where they are. But that is not the case in clients with frontotemporal dementia. In frontotemporal dementia, spatial orientation, what is that? Spatial, is that the opposite of ordinary? Like special halo-halo in the Philippines? No. Spatial means orientation as to space, as to the area around you. In frontotemporal dementia, they are oriented as to space. So therefore, 1 is not the priority. So the best answer is to prevent aspiration because of their impaired swallowing. Okay. Okay, for those of you, once again, who may want to join me for an extended period of time, see you in my 45 days Power Pack exclusive NCLEX RN test preparations that begins on September 11, and we will have this for a limited slots only. Okay. So let's learn together. If you have any requests, send in your request to my email, mentor.raygapuz@gmail.com. So this is your mentor Ray saying, a functional concept a day keeps your NCLEX RN fears away. So if you want to pass your NCLEX RN on your first try, join me, your mentor and your fact check buddy as we engage in an NCLEX learning session. So if you love this video, please don't forget to subscribe, share, and hit the like and bell notification button. Share it to your friends. If you share it to a minimum of 10 of your friends, You will pass the test with a minimum number of items of 75 and the shortest duration of time. If you want to request for the handouts related to what we have in this video, please send us an email. Hi, this time let me provide you with more sample questions related to the concept of BPH, or benign prostatic hypertrophy. So this is your mentor Ray, your fact check buddy. First, let's greet our passer. Congratulations to Mark Eugene de Peralta of the University of Northern Philippines, my fellow Ilocano, northern part of the country, who passed the NCLEX RN for the State Board of the Northern Mariana Islands Board of Nursing. That's July 10, 2021. Congratulations, Mark Eugene de Peralta. We are so proud of you. Okay, for those of you who want to be like them, join me in my 45 days Power Pack exclusive NCLEX RN test preparations class, which will start on September 11. To know more details, send us an email. So join us in this mission. Our goal is to provide free NCLEX RN application review to 100 nurses. And to help us achieve this, just watch and finish the ads in our videos. Thank you. So here are more questions related to the concept of BPH. Let's try answering sample questions. Here we go. The nurse is about to insert a catheter to a client with benign prostatic hypertrophy. What is the primary reason for lubricating the catheter? Is it 1, to prevent infection, 2, to decrease spasm of the bladder orifice, 3, to reduce friction along the urethra, 4, to prevent formation of encrustation at the bladder sphincter? The best answer would be definitely to reduce friction along the urethra. Okay, in order that the patient will not have too much discomfort. Next, which of the following manifestations occur in benign prostatic hypertrophy? Let's begin. Difficulty starting the flow of urine, yes. This usually occurs because the enlarged prostate would press on the urethra, okay, resulting into difficulty starting the flow of urine. Frequent nighttime voiding or nocturia, this is expected in patients with benign prostatic hypertrophy, yes. Voiding at more frequent intervals, we call this frequency, yes, because they are unable to completely empty the bladder. That's why they void very, very frequently. Greater force of urinary stream, no. They have decreased force, okay, of urinary stream because of the obstruction in the urethra. And then decreased frequency of urination, they have increased frequency of urination, not decrease. Okay. Now, next, here's another question. Which of the following statements about finasteride are true? Select all that apply. Crush tablets should not be handheld by pregnant women. Yes, because it could be absorbed in the skin and may cause birth defects in pregnant women or women who are about to become pregnant. Okay, so we put a check on that. It is used for treatment of hair loss. Yes. Okay. It can cause erectile dysfunction in males. Yes, studies have shown that it could potentially cause that. It should not be taken with sildenafil. No, the one that should not be taken with sildenafil is your Viagra, because is your nitroglycerin, rather. Sildenafil is your Viagra, because combining sildenafil with nitroglycerin could cause fatal hypotension. Then breast lumps in male normally develops. No, the breast lumps may potentially indicate breast cancer in males. Okay, so once again, this is your mentor, Ray, and your fact check buddy, inviting you, if you want to join me in my 45 days Power Pack exclusive NCLEX RN test preparations that starts on September 11, send us an email and we'll be glad to address your inquiries. So let's learn together. If you have any requests, you may want me to focus on my future videos, send in your request to my email mentor.raygapuz@gmail.com. So this is your mentor Ray saying a functional concept a day keeps your NCLEX RN fears away. If you love this video, please don't forget to subscribe, share, and hit the like and bell notification.